Hello, and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for August 16, 2023. Thank you for joining us this month. Our presenter today is Linda Lee. Dr. Lee is professor and Harold Robinson / Arthritis Society Chair at the Department of Physical Therapy, University of British Columbia, and senior scientist at Arthritis Research Canada. She also holds a Canada Research Chair in Patient-Oriented Knowledge Translation. Dr. Lee's research focuses on the integration of digital tools in rehabilitation, including the use of wearables and apps to promote physical activity in people with arthritis and in older adults to prevent falls. Dr. Lee's work in knowledge translation and implementation science has led to a new line of studies on strategies for engaging with patients and the public in the research process. The title of today's presentation is The Use of Digital Technology to Support a Tailored Approach to Physical Activity in People with Arthritis. Welcome, Dr. Lee.
Thank you so much for the kind introduction, Nick, and welcome everyone for joining this Lunch and Learn. And I see a few of friends and colleagues here, so wonderful to see everyone, even we're just online. So I'd like to share, well, first of all, thank you, Osteoarthritis Action Alliance, for inviting me to present in this session. I am a physical therapist by training and a health services researcher and an implementation scientist. So one of my passion is really to bridge the gap between what is known and what we do. And that's sort of what our focus is today. Now, one of the things that we do quite a bit is to help people to live a healthy, physically active lifestyle. Now, we all know that moving more, sitting less is a good thing for our joints, for our hearts, and our mind. But we know that there's so many examples around the world that people are, simply just not taking advantage of the benefits of being physically active. So for instance, from where I come from in Canada, if you look at the latest report on physical activity participation from Statistics Canada, about 45% of the people reported that they met the physical activity guideline recommendation of the 150 minutes of moderate to vigorous physical activity. Now, I primarily work with individuals with rheumatoid arthritis in my research, and one of the things is to engage in strength training as part of their self-management routine. And we know that about only 14% of people with rheumatoid arthritis engage in regular strength training exercise. So despite all the benefits, we're just not getting the message across, and that is where the passion of my research is to help to bridge this gap between what we know and what we do. So the agenda for the next 20 somewhat minutes is really to talk a little bit about the implementation challenge of physical activity and arthritis management. I also want to talk a little bit about the effectiveness around tailored self-management interventions to improve health and behavioral outcomes. And finally, I'm going to explore a little bit about the role of digital technology in supporting an active lifestyle. Now, you see the scan code on the screen. If you have your camera handy, please take a picture of that. I have all the material that I refer to, and perhaps you would like to have a look in this under the scan code. So the link is active until September 15th. So if you want to download anything from this link, please feel free to do so in the next few weeks. And I'm going to show the scan code again throughout the presentation. So if you miss it right now, don't worry. Now, we know that high quality evidence-based guidelines are really a good source of knowledge to apply in clinical practice, and we want to apply that in an equitable manner. But we also know there are many examples that guidelines are not fully incorporated in clinical practice. take osteoarthritis as an example. I think some of you who attended my presentations may have seen this slide before. And this is actually a point of my frustration. If you look at the guidelines back almost 20 years now, that on osteoarthritis management, exercise and physical activity is consistently listed as something that we need to do as a first-line treatment. But of course, again, we know that the message is not necessarily coming across to a lot of our people we work with and our patient population. So really, with the evidence and the guideline recommendations around exercise and physical activity, the issue here is not about knowing what to do, but it's about helping people to actually start and stay being physically active. So in essence, changing people's behaviors. Now, one of the challenges for health professionals to tailor their physical activity recommendation is the fact that people spend their time differently within their 24-hour days. This is a study led by Dr. Lynn Feehan, who analyzed the 24-hour profile of people with arthritis from a set of studies that we did several years ago, including people with osteoarthritis, rheumatoid arthritis, and lupus. We asked them to wear a research-based activity monitors over a 24-hour period for a week. And so what we found was that, on average, if you look at the profile in the middle, so we have all the activity that people were doing, including when the sensor was off or taken off the body. So, no surprises, people were, sitting quite a bit, when people at baseline when they were participating in our studies. But what we also found was that when we look at how people live their 24-hour days, they are nicely spread into 4 different clusters. So some of them were actually living a pretty balanced lifestyle. They maybe, they could use a little bit more or a little less sedentary time because they were still sitting about 9 hours a day. But they were, accumulating about, 7 hours of sleep, which is a good, healthy amount of sleep at night. So this is a pretty balanced lifestyle. We also found that people, a cluster of individuals who sit, quite a long period of time. But we also found that amongst those who sat a long time in the day, some of them actually accumulated a lot of sleep. And some of them were not sleeping enough. So knowing that, people actually spend their time in the 24-hour days in different ways, what it suggests is that, people may be physically active or not active because of their ability to engage in activities, opportunities that is available to them to exercise or being physically active. And so if we're developing interventions that not necessarily adaptable or flexible, the one-size-fits-all approach generally is not going to be able to achieve an extraordinary outcome that we would like to see. So one of the things was I was really excited when the Canadian 24-hour movement guideline was released. That came out in October 2020, right in the middle of the pandemic. So the nice thing about this guideline was that in addition to the focus around the 150 minutes of physical activity, it also give recommendation to highlight that we need to incorporate a healthy amount of light activities in the day. So several hours of walking slowly, doing things in a standing position, those are good things. It also recommends that people need to accumulate about 7 to 9 hours of good quality of sleep if you're adult between age 18 to 64, and about 70 to 8 hours if you're age 65 or over. Now, sitting, resting, being sedentary during the awake hours is not necessarily a bad thing, especially for people with chronic conditions like arthritis. So 8 hours of sedentary time per day is actually, a good thing for people to have. However, within those 8 hours, we should limit any time to spend for recreational screen time. So 3 hours or fewer of recreational screen time each day was what was recommended. So by refocusing the balance on the balance of activities within a 24-hour days, I think we as clinicians can now begin to really design strategies that really tailor to support people according to their ability and the opportunities to engage in physical activity. I think people also, it's a different way of thinking about counseling people to be physically active. So instead of focusing on the 150 minutes, now it's really about shifting people's sedentary time to engage in physical activity at any level, because they're all good for people to stay healthy. For people with arthritis, I think this approach may be more acceptable, especially when people's activity pattern may change when symptoms fluctuate. So it highlights the importance for clinicians to address sleep and fatigue when they're co-designing physical activity interventions with their patients. So with these new guidelines, it really helps us to reimagine how to support people to be physically active. But let's take one step back. Prescribing or recommending exercise and physical activity is not as simple as we think. It's a simple treatment, but the delivery is really complex. So when we're prescribing exercise, oftentimes people are thinking that, well, you do an assessment, you look at what is needed therapeutically, you then, recommend the right type, the right dose, the right frequency, and the right progression. If you do all of those things right, the world will be a better place. But it's not that simple. The success of the treatment also depends on how it's being delivered. So oftentimes, whether people are doing the exercises or being physically active as recommended, oftentimes also depends on how the clinicians or the exercise professionals talk to the individual. So the clinician or the exercise professional have the time to explain what needs to be done. Did they have the time to find out, sort of what are what are some of the opportunities or barriers that people may experience? Did they have the knowledge to tailor the physical activity or the exercise for the individual? Did they use the right tone? Did they use the right choice of words when they were explaining the exercise or ways to be physically active? All of those goes into that complete package when we're talking about delivering physical activity counseling or when we're prescribing therapeutic exercises. So now some of our patients may need to try out a new behavior when we're asking people to do exercise or to change their lifestyle to be more physically active. They may actually need to try out new things. So I like to show this study in most of my talks because it was just so nicely show the importance of thinking about the use of behavior change techniques. So this was a systematic review by Dr. Jasmine Ma, looking at 24 studies on the behavior change, on the influences of different behavior change techniques on the effect of physical activity interventions. Now, she didn't only include individual or studies with individuals with arthritis, so it's a broad populations that she was looking at. So what she found was that First of all, interventions that use behavior change techniques as compared to interventions that are that were sort of put together in a way that may not be informed by behavioral theories. So the ones that use behavior change techniques tend to work better and has a small effect compared to ones that did not include the use of behavior change techniques. But in this systematic review, they also look at the actual techniques that's being used in the physical activity delivery. So what they found was that interventions that included certain behavior change techniques like self-monitoring with feedback, like problem solving, and action planning, those are the type of interventions that actually work better than physical activity interventions that didn't use those behavior change techniques. So what it suggests is that there are certain techniques that works better in terms of helping people to start and stay being physically active. So based on some of the learnings, we have developed an intervention in the past number of years to look at how to do physical activity counseling better. And the population we work with were primarily people with osteoarthritis, rheumatoid arthritis, and one of the studies we also included people with lupus. We included education sessions. We worked with physical therapists who had training in brief action planning to work with patients in terms of goal settings and monitoring their goals. We provided a wearable device, a Fitbit, for the patient participants, and we also work with some of our patient partners to develop a visualization that pairs with Fitbit better to show the physical activity information that is more in line with what patients would like to see. And we also set up opportunities for the patient participants to have counseling sessions in every 2 weeks duration for in some of our studies to revisit their physical activity performance and to revisit their goals over time. So what we found was that in our studies, in general, it was feasible to implement. First of all, it can be done in the community-based setting. We work with physical therapists. Actually, some of them did not have a large arthritis caseload to start with. So what it meant is that we actually can involve more of the health professionals who don't necessarily work regularly with people with arthritis to increase capacity to provide these kind of counseling for people with arthritis. In our set of studies, we found that first and foremost, it helps to improve people's physical activity participation. So this is one example that we did a meta-analysis of our own studies and found that on average, it increased about 1,000 steps per day for individuals, and which was a small effect size that was in line with interventions that was looked at in Dr. Ma's systematic review. Now, some of our studies were included in a subsequent systematic review that was published in 2019 by a group in Australia. And what they specifically focus on was for people with arthritis, they look at whether using a wearable device alone or using a wearable device plus other components of with the interventions, for example, counseling from a health professionals, and how effective it is compared to a control. And there's no surprises. Interventions that use a wearable device alone, it works, but it has a very small effect. And when we include other components, such as counseling with health professionals, the effect was more prominent, which again, it was in line with some of the work that Dr. Ma did with the general population. Now, the systematic review from the Australian group was incorporated in an umbrella review that was recently published. This in Lancet Digital Health. So what they did was to look at the effectiveness of wearable-based intervention on physical activity, regardless of the population that they were looking at. So they have a mix of people who with chronic conditions and people without chronic conditions. And this umbrella review included 39 systematic reviews. And what they found was that using wearables for self-monitoring does have its value in improving physical activities. So they found that, using those type of devices helps to improve approximately 1,800 steps per day across populations, extra 40 minutes of walking a day, which is great. And in terms of moderate to vigorous physical activity, it increased approximately 6 minutes a day. Now, you may say that, well, 6 minutes, big deal, doesn't seem that it's a lot. But the authors of this study did know that if you consider an increase of 5 to 10 minutes per day of MVPA is generally considered meaningful at a population level, then the degree of change found here is probably clinically important, which I think is a very encouraging message for us. Now, the evidence that I just shared was based on a comparison with self-monitoring with the device, compared with the control. Witrowski, which is the study that I'm showing right now, and his colleague, we actually pushed that one step more. So in this systematic review, they look at the meta-analysis, they look at whether adding another component that are intended to improve physical activity to self-monitoring itself, whether it's better than self-monitoring alone as a control. So this review included 75 studies, and what they found was that when you combine self-monitoring with other interventions to improve physical activity, it on average increased about 900 steps per day. Now, what was interesting was that at follow-up, which was the period when those additional components, so maybe education classes or counseling or using other things on top of the self-monitoring. And what they found was that people were still walking more if they were exposed to using the device plus those other components. So and it decreased a bit from the 900 steps to 400 steps per day, but it was still statistically significant as compared to people just use the device alone. Now, what was also interesting was that the only additional component that shows that contributes to the significant effect at follow-up was when people receive telephone or video counseling as the additional component. So I think the taken together, the body of evidence is really suggesting that self-monitoring with devices has its value, but having someone to guide individuals to develop this habit, a way of being more physically active, or include their therapeutic exercises as part of their daily routine is important in building the habit and sustaining it over time. I'm going to finish by touching on a little bit around the use of technology in improving self-management. Now, self-management is a tricky thing. It's complex. When you talk to people with arthritis, they will tell you that maintaining an active lifestyle, people know that is important, but it's hard because symptoms may change from day to day. And it is difficult when people don't know what their normal, quote unquote, normal pattern looks like. So, so it's hard to understand whether, the symptoms is, how, how, like in response to the symptoms, how they should modify their self-care efforts and daily activities. Now, despite the growth in acceptance in digital tools, I think that people with arthritis has been mostly left behind. We work with patient partners, and oftentimes we hear that people want to have a tool that give a dynamic picture of their symptoms in their daily lives between their health professional visits. They also want to be able to share this picture with health professionals, and they also want a tool to help them decide when they need to seek help when their symptoms fluctuate. So 3 years ago, we developed a tool called Arthritis, and this is a platform that was co-developed with researchers and patients as well as clinicians to help improve people self-monitoring activities. So what it does is that it's a platform that has an online journal to monitor symptoms, disease activity, and treatment. It has a way to sync, for people to sync and see and understand their Fitbit data on physical activity. And it also comes with a companion mobile app that's really simple for people to input their self-rated information around their pain, their mood, or their fatigue level whenever they feel they're able to do that. And it also has a way to easily share the data with their healthcare provider during the visit. So we are just recently completed a randomized control trial. If you go to the scan code that I showed earlier, you're going to find a study protocol. And let me just show that this is one of the sessions that we had on the left that the therapist was doing the counseling, showing people how to use their Fitbit, and in the initial group session. And on the right, you kind of see the dashboard of how Arthritis work for individuals when they are tracking their symptoms over time, and how it can overlay with their physical activity level to understand sort of what they do in relation to how they feel over time. I just basically sum up 9 years of things that we've done since 2014. The whole story started in 2014 when a patient group worked with us. Arthritis Consumer Expert was the group that helped us crowdsource, our priority setting of what was important, things that we should focus on when in improving physical activity. And that led to a collaboration with Dr. Deanne Lakai's group, who did the Arthritis Health Journal for self-monitoring. At the same time, in 2017, we were testing those, the Fitbit and the Fit visualization studies. By 2019, we developed the app. We tested it. We completed the RCT, and last year, we actually got an award from the Arthritis Society in Canada for the Arthritis platform that we've developed. So I'm going to hold the result for the study because we submitted an abstract to the ACR conversions. And for those of you who are going to be there, I'd love to share the results with all of you. If our abstract get accepted, and we'll see you in San Diego. So in summary, I think supporting people to move more, sit less, and sleep better, we all recognize is a complex task. I think using digital monitoring tools as well as counseling can help support people to engage in physical activity. I think there's huge opportunity to continue research in this area. We need to find better ways to design our monitoring and counseling strategies, especially not just for physical activity, but the other side of the balance around better manage rest and sleep. And also, we need to understand a lot more in terms of the different implementation strategies in different contexts. just want to, show my gratitude for all of these wonderful individuals, especially the patient partners on the top of the slide. Without these individuals, none of what I just presented was possible. With that, thank you, and I'm happy to take questions.
Very much, Dr. Lee. You left us with the cliffhanger. So hopefully some of us will be able to attend that conference to find out the results. I got a couple of questions while you're presenting. The first one concerns the operas. Does it only sync with Fitbit, or does it sync with any other fitness wearable?
Yeah, so it only syncs with Fitbit. Now, we develop operas as a conceptual tool. So this is not something that, it's, with a huge budget, huge production that, is designed to sync with multiple different devices. We would love that. But what we see is, sort of the first step to see if we can sync wearable data with people's self-reported symptom monitoring data. Is it going to make a difference? And one of the things I can mention that our primary outcome was actually on patient activation. So we want to see whether the intervention help people to increase their ability, their capacity to self-manage and engage in self-care activities better. So at this point, it only syncs with Fitbit. I'd love to work with individuals who are interested and, sort of expand this line of work and to be able to sync with other devices as well.
All right, perfect. And one more question. Since the general goal appears to be shifting from a sedentary lifestyle to patients incorporating basically any movement, would you prefer to use that Fitbit or an accelerometer for research studies?
Very interesting question. So our study has been designed in a way that we want to use things that people are using. So at the time when we started, Fitbit was one of the devices that was relatively affordable. We used the baseline, or not baseline, the base model device that hopefully more individuals can afford it, and so we use so we primarily use Fitbit as a way for people to self-monitor and get that feedback around their and understand their physical activity and understand how they actually move during the day. And that's why we build a visualization to sync with the Fitbit to lay it out better in terms of where people were active, where people actually break up their sitting during the days. And so in terms of using accelerometer, especially the research-based accelerometer, I think it's still very important as an outcome measure. In 2018, we published a systematic review looking at the quality of data tracked by Fitbit. That's also led by Dr. Lynn Feehan. And the verdict at that time was that if you're not walking at a steady pace or jogging at a steady pace, Fitbit is not that good in terms of tracking what you do. Now, I said it was, at that time because, Fitbit is since acquired by Google and they're using a lot of analytic and AI that's proprietary. We don't know what they're doing, but I would imagine that the way that it's measuring physical activity is hopefully better. But at this time, we would still recommend using a research grade accelerometer or a sensor. We use the SenseWear device to measure physical activity in our studies. You use it as an outcome measure.
Very good. We got one more question, and it kind of goes along with what you're saying about AI. Are there any AI-enabled functions that you've looked into for decision-making support, or maybe predicting poor recovery post-surgical or otherwise, or redesigning care delivery pathways?
Sorry, can you repeat it? It
Sure.
was missing a little bit at the end.
No problem. Are there any AI-enabled functions that you have looked into for decision support?
Yeah, no, that's a good question. We have not at this point. Again, we were testing the concept whether the self-monitoring and the visualization, basically testing the combination of behavior change technique, whether it actually makes a difference in improving self-management or self-care capacity. So the goal is that as we continue on with the study and with more people using devices in programs like Operas, the program or the data being collected can can certainly be looked at in terms of using machine learning and AI to understand what's going on when individuals symptom changes over time. Very interesting thing is that when we work with our patient partners, oftentimes they come back and say that, well, it was interesting to see the progression of my physical activity over time and how the changes of my medication dose was happening during that time. So now you sort of get an idea of understanding, so what does my norm look like now? That it's a less precise way to do it as compared to using AI, but the ingredients are here for us to move further. So again, anybody who's interested in working in this area, I would love to connect with you, to collaborate.
Absolutely. Well, thank you very much, Dr. Lee, and thank you to everyone who attended today's presentation. And in just a moment, we'll launch a brief satisfaction poll. Please answer those questions before you leave the webinar. And finally, we hope you will join us next month on September 20th, 2023 for our Lunch and Learn featuring Carmen Roldan, who will present Reaching Out to Engaging Hispanics, Lessons